Good morning, everybody. So we come up here and we talk about where we've trained and our titles, but really the king in my household is my corgi, and that's the breed of dog that's on here. He's the big boss. And I thought it was appropriate because we're going to be talking about the disease of kings as well as hyperuricemia. So again, my name is Dr. Sehriban Diab. I'm a consultant rheumatologist at Sheikh Shakhbout in Abu Dhabi. So our objectives will be an approach to hyperuricemia. We're going to talk a little bit about the epidemiology of gout, risk factors of gout, diagnostic tools used in diagnosing gout, and treatment in 2023. I will focus on treatment because I find that in our patient population, by the time that we see patients, they've usually already been started on treatment, and sometimes we don't agree. So I think in this specific conference or crash course, it's very important to focus on treatment. I want a raise of hands. Who here has eaten or drank one of these things in the past week? All of you. Cookies, soda, come on guys, yogurt, processed yogurt, cookies. Really? Okay, I thought so, okay. I thought it would be way more. You guys are a very healthy population, good for you. These are all very high in purine. And unfortunately, though they're extremely tasty, they end up being converted to uric acid. And you have to understand that in our head, we keep thinking red meat, red meat, red meat soda. But actually, lots of different kind of shellfish, especially here in the UAE. We eat a lot of fresh seafood, and it's delicious. What about all the processed things that we ourselves eat, and as well as the kids, right? Little yogurts, cookies for lunch, tiny little cookies, burgers and fries. Just keep an open mind because anything processed is very high in purine. Okay, so flow charts. We do a lot of teaching, and I really do like focusing on flowcharts because it gives you an approach. One of the things that I wish I focused on more in medical school is approach 2. Because when you do a full approach, you rarely miss things. So with uric acid, there's 2 ways that it's going to accumulate in your body. You're either under-excreting it or you're overproducing it. Okay? Keep things simple in your head, which we have here. You're either under-excreting or overproducing. So let's focus on under-excretion. So there's a few things that can cause under-excretion. The first one, hypercalcemia, sarcoidosis, hyperparathyroidism, and different causes of hypercalcemia. The calcium ends up accumulating in the renal tubules, which causes a decreased ability of the kidneys to filter uric acid, so under-excretion. The uric acid accumulates. What about medications like ACE inhibitors and cyclosporin? What do? They inhibit vasoconstriction in the arteriole going to the nephron, efferent arteriole in the nephron. It decreases your eGFR and again, accumulates uric acid. You can't excrete it. What about tubular poisons? How many of our patients are on low-dose salicylates? So many patients. Diuretics. How many of our patients are on diuretics? Organic acids like lactic acid and keto acids for our patients with DKA and diabetes. I mean, how many of our patients have diabetes? This poisons the distal convoluted tubule in the nephron, decreased secretion of uric acid from the blood into the nephron, and under-excretion of uric acid. Ultimately, hyperuricemia. I mean, just looking at this chart, how many of our patients are at risk of hyperuricemia? I didn't necessarily say gout for a reason, which we'll get to. Now, lymphoproliferative disorders, hemolysis, and psoriasis, especially in the rheumatic population, causes a rapid turnover and lysis of cells increased breakdown of DNA, release again of purine, and overproduction of uric acid. Now, we just also know the overproduction of uric acid has a lot more causal factors, such as intake. And I think, especially in our patient population, intake is a big one, as well as weight, which we'll get to. When you get hyperuricemia, unfortunately, it accumulates both in the blood and ends up either going to joints, causing acute or chronic gout. It can be with or without tophi. And unfortunately, the uric acid can also accumulate in your kidneys, causing nephrolithiasis. Very important to note that isolated hyperuricemia may not be clinically important, and I beg you to please take note. Isolated hyperuricemia may not be clinically important. Every time you see a high uric acid, you do not have to necessarily treat that with medication. Okay, moving forward. So we talked a little bit about different kinds of things that cause hyperuricemia, but we should also note there are some genetic factors. I see a lot of young men in our patient population, and some of them don't even have, obesity, and their diet is not necessarily, high in purine. And I always wonder about these genetic factors. So ABCG2, GLUT9, URAT9, there's lots of different little transporters of uric acid in the kidneys. And unfortunately, if one of them has a genetic mutation, the uric acid will not be transported appropriately, and it'll accumulate, and you'll end up getting gout. There's also XOR gene in the liver, and if that has a genetic mutation, that also causes high uric acid. Unfortunately, here you can see that when your uric acid levels increase, not only can it cause gout and CKD, but it also causes high cardiovascular disease risk. More and more, we've been realizing that gout, yes, it can cause problems with the joints and the kidney, but because of the inflammation that it causes, it increases our cholesterol levels, and over time, if you don't control that, that patient is at risk of early onset cardiovascular disease. This is from Up to Date. I thought that it was important to put something like this because honestly, obesity, hypothyroidism, chronic renal insufficiency, a volume depletion, heart failure, fluid losses, all things that we likely see every single day in our clinic. You have these other, rare genetic things, which you don't see very often. But then if you look at the drugs, things like diuretics and low-dose salicylates, again, very common. Levodopa, very common if you have, that specific patient population in our hospital. So just keep an open mind. And don't think that the only thing, that you need to focus on is intake and red meat. Just know there's lots of different factors that can cause gout and hyperuricemia. Now, why do we care so much about gout? Why are we, having this lecture? Why are we focused on it? The global burden of gout is steadily rising. The global prevalence used to be 0.08%. And unfortunately, it increased and now is ranked 138th in terms of disability. And for me, the age of our population globally is rising. Obesity rates are rising. Processed foods are rising. So this is something that we're going to be seeing more and more often. So it's very important that we all have a very good understanding, not only of what causes it, but how to manage it. Usually we see gout increased incidence in men in the 4th and 5th decade, and women in the 6th and 7th decade. But these observations suggest that there's an average period of asymptomatic hyperuricemia of at least 10 years or more in both females and males. Hyperuricemia is a necessary but not sufficient precondition to develop urate crystal deposition disease, and it's very different than gout. Most hyperuricemic individuals never experience a clinical event. So in our in our hospital, we've looked at studies because I see so many asymptomatic hyperuricemia patients who came in with an ankle sprain and their history, they injured their ankle and they've been having pain for 2 months. They go into the emergency department. Their uric acid is high because of obesity, and they're started on allopurinol. For me, allopurinol, to a lot of doctors may not seem that much of a big deal, but there's fatal side effects to allopurinol, allopurinol hypersensitivity syndrome being one of them. So I was interested, and I said, I wonder if anybody has done a study about allopurinol and allopurinol hypersensitivity syndrome. There was a study done, I think it was in Singapore, I should have put it here, but I didn't, and they calculated how many patients developed allopurinol hypersensitivity syndrome. And basically, there are patients who had died from allopurinol hypersensitivity syndrome that didn't even warrant starting uric acid lowering therapy in their hospital. Fatal effects of allopurinol for patients who did not even need it. So I thought it was very important to say, most hyperuricemic individuals never experience a clinical event of actual gout. So let's look at an approach to acute and chronic gout. So we talked a little bit about the pathogenesis, and we talked about different things that can cause it. Alcohol intake is one of them that we didn't really mention. But it's very important to ask your patients this question. I know it can be uncomfortable, but it needs to be asked. We talked about the approach to hyperuricemia, and with alcohol intake, you can get, again, the lactic acid that we talked about, and increased uric acid. So when the uric acid concentrations in the blood leak into the joint, the uric acid crystallizes in the joints, and unfortunately, when you get repetitive trauma due to weight bearing, or you get, very dehydrated, you can get effects in your big toe, ankle, knee, and wrist. But frankly speaking, advanced gout can even go into your spine. So again, keep an open mind. When the uric acid crystallizes in your joint, you can get activation of the complement cascade and leukocyte chemotaxis. The neutrophils enter the joint to try to phagocytose the crystals, and the needle-shaped uric acid crystals actually puncture the neutrophils, and they release degradative enzymes into the joint space, and you get this chronic gout. I'm not going to go into everything right now because we'll talk about this later, but the needle shape of the crystals, we always learn about it, and you can see here how that needle shape is relevant. It actually punctures the neutrophil like a needle, and I thought that was neat because I'm a bit nerdy. Okay, risk factors. So for every single disease, we have non-modifiable and modifiable risk factors. The non-modifiable risk factors like age, gender, ethnicity, and genetic variations are very clear. Now, please focus on these modifiable risk factors. Obesity, hypertension, hyperlipidemia, cardiovascular disease, diabetes, chronic kidney disease, dietary factors, alcohol, and medications altering urate balance. I'm sure every day in your clinics, you see all of these risk factors, maybe even in one patient. When I see a patient with asymptomatic hyperuricemia, I promise you most of my time is spent talking about these modifiable risk factors, especially if they're young. If somebody is young, I always give them a chance, and I explain to them that this disease not only causes gout and potential nephrolithiasis, but it can cause premature cardiac disease, stroke, and believe me, I've had multiple patients lose copious amounts of weight just because of this counseling. So please focus on the modifiable risk factors in your patient population when counseling. Now, so this is a diagnostic tool that basically is used for clinical diagnosis of gout. If the patient is a male, they get 2 points. Previous patient reported arthritis flare, and kindly note arthritis. If the patient has had a sprain or a trauma of some kind and a torn ligament, that is not arthritis. So focus on getting a good history and doing a good physical exam. If it was a very acute onset, if someone's coming to you with a 2-month history of the same joint hurting, that's not gout, right? Gout is an acute thing. It lasts up to 10, maximum 14 days. So just make sure your history is very clear in terms of time. Joint redness, first MTP involvement, hypertension or at least one cardiovascular disease, and a serum urate level over or at 350. So the more points you get, the higher the chance of gout, kind of self-explanatory. But this is your full approach. So first of all, you clinically have to have a suspicion of gout. If you can aspirate that synovial fluid and analyze it, that would be great. And if you have negatively birefringent needle-shaped crystals that are characteristic of monosodium urate crystals, seen in the synovial sample in polarized light microscopy here, you can see the blue ones. Okay, those are needle-shaped crystals. The others are just kind of a reflection of them. This is diagnostic of gout. As you can see, the rhomboid-shaped crystals here are CPPD. So if you've confirmed the diagnosis, great, done, you have gout. Now, if you can't see, if you take a sample of that synovial fluid and you don't look at it immediately, big chance you won't find the crystals. So when you actually see patients with their synovial fluid analysis saying no monosodium crystals, you should ask your lab, how long did it take to analyze that sample? Because if it took too long, it's like there's no point. So you should actually be putting a rush order to get that sample analyzed as fast as possible. We actually ask our really helpful porters to be there while we're doing the aspiration and run and get this sent to the lab as fast as possible. So if you don't find it, that doesn't mean that it's not there. Do you have an alternate diagnosis like CPPD, infection? Maybe it's rheumatoid, you know, like it was just presented. So if you do have an alternate diagnosis, fine, go ahead and work that up. But if you don't have an alternate diagnosis and you really, really think it's gout, based upon clinical and some synovial fluid findings like neutrophilia, then you have to apply the diagnostic tool, and based on the score, you give them a probability of gout. But if you don't think that, you know, this is clinically gout, then go ahead and do further evaluation. I think it's pretty self-explanatory, simple, but most importantly, analyze the synovial fluid fast. Treatment. So honestly speaking, whenever, you know, we're teaching in an exam scenario, we always say, remember, treatment is pharmacologic and non-pharmacologic. I mean, how many times have we said that to our trainees? In the pharmacologic setting in gout, the acute and the chronic treatment are very different. So we have a lot of pharmacological treatment in terms of xanthine oxidase inhibitors, allopurinol, febuxostat, xyluric, fiburic, uricosurics like probenecid, and then we have IL-1 inhibition. We also have your typical acute NSAIDs, prednisolone, and we'll talk about this a little bit, but I wanted to talk about it using guidelines. So I mean, for us, you know, evidence, 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 and in rheumatology, I think that, you know, our patient population have rare diseases. We can't do a lot of huge randomized controlled trials. So we really depend a lot on these guidelines and expert opinion to really help us. In 2020, the American College of Rheumatology got together and they made new guidelines for the management of gout. So this is for the acute management. And as you can see, if something is really dark green, it's strongly recommended. And believe me when I say in rheumatology, we don't get a lot of strong recommendations. So when we do, we hang on to it. So if a patient has a gout flare, we strongly recommend using oral colchicine, NSAIDs, or glucocorticoids. When they've done studies, they found that 3 of those medication lists have the same equal efficacy. So there's no need to choose one versus the other. And the steroids you can give oral, intra-articular, intramuscular, as appropriate for first-line therapy. Over IL-1 inhibitors like anakinra, extremely expensive. or ACTH. So the choice of colchicine, NSAIDs, or glucocorticoids should be made based on the patient factor and preference. But if you choose colchicine, use low-dose colchicine over high-dose colchicine because it's similar efficacy. You don't want them having severe diarrhea and stopping the colchicine. Now, what's another strong... Oops. Oh, am I out of time? Just a few more. I'll just do one, like maybe a couple more, and then I'll stop.
Okay.
Okay.
Go ahead, yeah.
Thanks. So maybe I'll just move forward to the chronic. So essentially, another strong recommendation, if you have tophi, you have to initiate uric acid lowering therapy. If you have any radiographic damage, you have to initiate uric acid lowering therapy. And if you have more than or equal to 2 flares per year, you have to initiate uric acid lowering therapy. Please, if the patient does not have one of those things and they don't meet criteria for uric acid lowering therapy, talk about the modifiable risk factors. Give them a chance to actually treat themselves, reduce their weight, change their diet before immediately giving them lifelong uric acid lowering therapy. I mean, this is the ACR, recommendations and guidelines, so you can go through it. But as you can see, there's lots of very nice charts, easy to read, very kind of clear. So there's definitely some things, population-based recommendations, some strong recommendations when switching uric acid lowering therapy, and management of concurrent drugs and lifestyle. So I'll let you go through those alone, and in the end we can take some questions. So thank you very much.